My name is Mathew, GP hospitalist, St. Paul's, also GP in the community of Saskatoon. And so my project is about cardiac telemetry. And so the situation is that we use telemetry at St. Paul's to monitor our patients at risk of cardiac arrhythmias. But in the literature, at least, there's evidence that telemetry is overused, leading to over-investigation, over-treatment, longer wait times in the emergency department, waiting for beds and telemetry, alarm fatigue on the part of our nursing colleagues, and also direct and indirect system costs. There is best practice in the literature, which is a strict telemetry admission criteria set, as well as a structured reevaluation kind of mechanism for telemetry patients. And so the plan was to improve the telemetry admission order set so that more people would make better use of it, and also to develop an algorithm for our telemetry nursing colleagues to use to identify those people who no longer needed telemetry and to get them off of this expensive technology faster. And so kind of the challenges that we faced between August to April of this year, only half of people actually had an order set done, regardless of whether they were seen by a resident, an internist, or a GP hospitalist like myself. Prior to January, there was dozens of MRPs with no kind of standard protocol for reevaluating these patients. Everybody kind of had their own thing to do. After January of 2019, with the hard work of nursing staff and a manager at the 5th floor of St. Paul's, the ACU was implemented, and structured interdisciplinary bedside rounds were initiated as well. And this was a huge change on the part of all the staff there. And so what happened, we're still kind of collecting the data, but initial results suggest a 12% decrease in the average telemetry duration for patients after the implementation of the ACU. There did not seem to be a change in the compliance to the order set, unfortunately, and there's no clear benefit as to whether people are waiting less in the emergency department to get to their telemetry bed. And so in terms of things that I personally learned, this project involved a lot of different people, and even within particular different tribes, that tribe also was massive and had a lot of different people, right? There's so many residents, there's so many hospitalists, and there's so many internists. You need kind of an internal champion from those groups to kind of help you advocate for your cause. Sometimes best practice means making things easier to do the right thing, and other times it just means making it impossible to do the wrong thing. Change fatigue was a big factor in the work that we did, especially with the implementation of ACU. That was pretty stressful, I think, for a lot of staff and physicians. At the end of the day, we got to focus on our common goal, which is what's best for the patient. So I want to thank all the people who were involved in the project and people who supported.